A warm greeting to all of you and welcome to Cardiac Rhythm and Intervention Society to be part of this academic feast on Atrial Fibrillation 2023 guidelines and in-depth focus on the relevance, especially in contrast to the Indian continent. So today we have with us Dr. Devinder Bist, who is eminent international cardiologist and active electrophysiologist in Chandigarh and doing complex cases related to atrial fibrillation as well. So he had a vast experience in this field and is active president of Cardiac Rhythm and Intervention Society. The guideline published in 2023 in the JAC, this underlined the effective treatment strategy for AF, and this uh, uh, basically this was a new change way back from 2014 and then focus update in 19 and now almost altogether new guidelines in 2023. Atrial fibrillation, as you all know, it is you can find in every corner of the hospital. You can find in ICU, in a surgical ICU, in a neuro ICU, in day-to-day practice, in your OPDs. So it carries a huge burden. And at last, we will also discuss what were the main scientific evidences that it happened in last decade, because of which there was a urgent need of change in the guidelines, and what is the relevance of these guidelines when we talk about the Indian continents and especially in our clinical practice. So without wasting a time, I would like to invite Dr. Devinder and I would like to put a first question. See, Dr. Devendra, atrial fibrillation is becoming increasingly burden in our day-to-day practice, and there is a huge uh, change in the practice because of the newer development in the electrophysiological field. So, I would like to ask, what are the what were the newer scientific development and what was the need that compelled the eminent uh, these bodies to change the guidelines, and what were the main change that is embedded in these newer guidelines?
Okay. Thank you, Dr. Kamal, for inviting me, and a very good evening to all the listeners who are present in this August forum. So, if we talk about the guidelines, so guidelines depends on what the evidence do we have for the management of a particular disease. So, atrial fibrillation, which represent a disease continuum, and it is being treated either by rate control or rhythm control. If we talk about 20 years before, we have two landmark trial, that is the affirm trial and the race trial, and those were published in 2002. And on those time, we have only medication to control either the rate or to maintain the rhythm. We do not have sophisticated gadgets like radio frequency ablation, cryoballoon, and PFA at that point of time. So we are either maintaining the rate or rhythm by means of antiarrhythmic drugs or certain nodal blocking agents. And it was shown on those trials that rate control is non-inferior to rhythm control because the advantage of rhythm control is being offset by the various complication reported with the antiarrhythmic drugs. And even DC cardioversion was not attempted in affirm trial, that was the landmark trial. In the race trial, they tried the DC cardioversion as a rhythm control strategy, but they found it was not very great compared to the rate control with beta blockers and calcium channel blockers. Then we have some advantage, some progress in the field of rhythm management by means of radio frequency ablation. And then comes the two other trials, that is the Castle AF trial, that in which the patient who are suffering with heart failure and atrial fibrillation, they were the rhythm is managed by radio frequency ablation, and they were compared that in those patients who do not underwent the rhythm control, they have shorter lifespan, and radio frequency ablation is increasing the life expectancy of the patient who are suffering with heart failure and atrial fibrillation. Then comes the Cabana trial, that is another landmark trial. But the problem of the Cabana is they enrolled a large number of patients in a medical therapy arm and radiofrequency ablation arm, but 30% was the crossover. That is the patient who are assigned to the medical therapy arm, 30% switch over to the radio frequency, and the patient who are assigned to radio frequency 30% cross over to the medical therapy arm. So that's why it is very difficult to interpret the Cabana trial, and Cabana trial is again a non-inferior trial. But if we do a sub study of the patient who are having some reduced ejection fraction, in those patients the radio frequency ablation is superior to medical therapy. And then comes the another trial, the East AFNet 4 trial, that shown that if we control the rhythm early in the patient, either by radio frequency ablation or by medical therapy, we find a superiority of rhythm control over the rate control. And then we have another trial, that is the three landmarks trial, that is the STOP trial, early AF trial, stop AF trial, and cryo trial. And these three trials are the landmark trial that enrolled the rhythm management by cryoballoon. And early AF was a Canadian trial. The the early AF was a Canadian trial. The stop AF is an American trial, and cryo is European trial. So the three trials that are being conducted in three large continents, and they found that the patient who underwent rhythm control by cryoballoon, they have a better life expectancy compared to the patient who underwent the medical therapy. So these, as we have more evidence for maintaining the rhythm control over the rate control, the guidelines has to revise, because previously we do not have the data for the rhythm control, but now we have more data, more gadgets, and rhythm control strategy is found to be superior. That's why the latest 2023 guidelines have enrolled the rhythm control strategy as a first strategy over the rate control, which is being used in the past days.
Yeah, thank you, Dr. Devinder, because there is a lot of things that has happened in last decade, and that has actually changed the way we should manage the atrial fibrillations. So, Dr. Bish, the previous ESC guidelines on AF management, they have been quite influential in the way that healthcare professionals should approach the AF. But with the introduction of these new 2023 guidelines, uh, we would like to know how these guidelines differ from the earlier version in terms of advancement in the field and integrated approach to the AF care. And can you also please walk through the most significant change or addition in 2023 guidelines, including any new or revised recommendations that healthcare professionals should be aware of? And no doubt the rest of the studies you have already been taken care, like early atrial fibrillation trial and stop atrial fibrillation AF trials. So, what is the main gross difference between those ESE and European Society of Cardiology and this ACC trials guidelines?
So if I talk about the differences, so first difference which I found that the previous guideline has categorized the AF depending on the duration, because AF is a disease spectrum. It involved the patient who are having paroxysmal AF, then persistent AF, then long persistent, and the permanent AF, or the patient who are having non-valvular AF. So the previous guideline has categorized the atrial fibrillation depending on the disease duration. But the latest ACC AHA guidelines has categorized the patient who are also at risk for developing atrial fibrillation. So they categorize basically at risk AF, pre-AF, AF, and the permanent AF. So they basically simplify the classification of atrial fibrillation and also give an insight for the prevention of AF in the patient who are at risk for developing atrial fibrillation. So this is the major difference which I found, and that is very helpful for the cardiologist to identify the patient who can develop atrial fibrillation in due course of time, And if we identify this patient and by means of lifestyle modification or by drugs that is targeted for the selective risk factor, we can prevent the development of atrial fibrillation. And
Absolutely,
if the patient is
there
and
is
if the patient is already
sorry, absolutely there is a this is a gross change where ESC or other agencies till date they stand that they should take care of AF once it is AF. But in ACC or AHA, they have now it is the they have changed the vision that you should treat it as a continuing spectrum. They should detect the risk factor and they should detect the electric or echocardiographic evidences that may suspect that put a patient at risk of developing atrial fibrillation uh, in the coming futures. And to add, we have some risk factor that is we have very good mnemonic that is head to toe. That means patient having heart failure, patient having the exercise imbalance, patient having arterial hypertension, patient having diabetes type 2, patient having tobacco, ethanol, or smoking. So, this is a very appealing mnemonic that can easily we can figure out in day to day practice. So, what is the main change you see, or you can see just in a brief? What is a take-home message if we go by these trials? What are the three major important take-home messages from these guidelines that one should always remember in day-to-day practice? And what are the scientific evidences or scientific bases on the basis of which these has been implemented?
So if I talk about the previous guideline initially focuses on the medical management for the patient who are having atrial fibrillation. And once the medical management fails, you should consider for the ablation part. But the latest guidelines, they targeting that the patient who are in the initial stages of atrial fibrillation, even in those patients, and if we can select the patient by various parameters, if we treat them by ablation in the early disease course, we can prevent the development of uh, complication which can develop later in the life, because the if you break the cycle early in the disease course, you can prevent electrical remodeling that will happen if the patient remain in atrial fibrillation in a longer period of time. So atrial fibrillation burden is being considered in the present 2023 guidelines, which is not very much clear in the previous guidelines. So atrial fibrillation burden is one thing. And if we talk about the data, what evidence do we have to prevent for the early rhythm management by ablation? So we have East AFNet 4 trial, that is in which the patient who are very early in the disease course, they were treated by the ablation, and they found a significant, the trial actually stopped early because they found a significant benefit in the early ablation arm. That's why they stopped the trial prematurely. And then there are the two trials, the early AF and the stop AF trial, that cumulatively enrolled around 500 patients, and all were treated by cryoballoon. And the number needed to treat is only four. That is a very good number. And they found that cryoballoon is having a superior edge over the medical therapy in the patient if we select them properly.
Yes, so these are the key finding. So prevent atrial fibrillation, change in the lifestyle to prevent burden of AF and early rhythm control, and is in some appropriate patients or some selected patients, cryoablation should be preferred over the antiarrhythmic drugs. This is the key message that is coming from this major trial. Another area of concern is, yeah.
One point I will add. So cryoballoon and radio frequency. Actually, it is not cryoballoon that is has superiority over radio frequency. Actually, cryoballoon is better because it has lesser complication rate compared to the radio frequency ablation. But if we talk about the cryoballoon has its own limitation because it comes in only two sizes, and it may not fit in all the patient's anatomy. So we have to select our patient very carefully when we are sending them for the cryoballoon ablation also. So it not about the cryoballoon, but it is in general the radio frequency, the cryoballoon or PFA, whatever we are considering, the ablation is the focus for the management of patient with atrial fibrillation.
So the evidences which are coming from these early AF trial or stop AF trial, as far as the data has been shown, that was in relevance to cryoablations only. So, do these cryoablation they also so RFA also will be equally effective in the heterogeneity, in considering the heterogeneity of atrial fibrillation populations, because not all the patients are suitable for cryoablation. So, do these findings also replicate the same way if you use radio frequency ablation rather than the RFA, or there are some inherent complications that are more frequent in RFA as compared to the cryoablations?
So either it is radio frequency, either it is cryoballoon, or whether it is PFA, the basic target is pulmonary vein isolation.
Okay.
And how we achieve the pulmonary vein isolation is by these three different modality what we have presently. If we talk about the ablation, it has certain complication that can happen during the procedure, and the complication are the determining factor what will remain in the due course of time. So if the PFA is having least complication and highest success rate, the PFA will succeed over the radio frequency and cryoballoon. If we talk about the cryoballoon and radio frequency, cryoballoon is definitely having lesser complication compared to the radio frequency, and it takes less time compared to the radio frequency. A general radio frequency ablation say take around 2 to 3 hours for a average patient. So cryoballoon takes half the time what the radio frequency will take. So that's why we are not only reducing the time of procedure, and by reducing the time of procedure, we are reducing the complication rate, and also the other complication that is being reported with the radio frequency are lesser. But yes, there are also complication that can happen with the cryoballoon. So it all depends on the time of procedure and also the complication that can happen during the procedure.
So, should we consider as a take-home message that it is the pulmonary vein isolations rather than the type of the way by which we are doing pulmonary vein isolations? So, pulmonary vein
Yes.
isolation is more. It is rather than more achieve more as you can say end point rather than achieving a bit by cryoablations or RFA or other modalities. So, is it so?
Yeah, ultimately is the pulmonary vein isolation, and in selected patient, some are also doing the posterior wall isolation or roof line. So it is not possible with the cryo balloon to do a better posterior wall isolation than the radio frequency. And those who are very skilled in using and manipulating the catheter of radio frequency inside the LA, they find it more convenient than cryoballoon to use to deliver the lines across the various walls of the
Maybe in
um,
future,
left
we
atrium.
will also have some head-to-head trials comparing both the strategies in replicating the results. So, Dr. Bist, if we talk about our Indian continent in our country, what will be the impact of this atrial fibrillations? Major key home take-home messages that we should. Yes, it is very easy to implement that we should take care of screening the atrial fibrillation. It's okay. We can manage the oral anticoagulation. And what is the impact of this guideline that we should consider cryoablation as a first line therapy as compared to the Indian as compared to the antiarrhythmic drugs in Indian context, considering the financial aspect, considering the burden of atrial fibrillations, considering the other risk factor associated with the atrial fibrillation in our continent.
Yeah, so finance plays a major part in treating the atrial fibrillation, because atrial fibrillation is a complex arrhythmia and it requires a dedicated team for the procedure. And if I talk about the cryo balloon is available in India. However, it is available in the select center because the console is immobile. So the hospital has to install the console, and only then we can do a cryo balloon ablation. So as the in South India, there are multiple patients who are being benefited by various radiofrequency ablation and cryoballoon ablation for atrial fibrillation. However, in northern part of India, it is available in minimal centers, and it is being utilized now in more frequent of the patient who are indicated. And I'm hoping that in few years down the line, the patient who are indicated will get the benefit of these technologies in their disease course.
So, Dr. Beast, just in the end, just would you be please uh, pinpoint the key take-home messages that we should uh, take took from these newly 2023 population guidelines in a very brief way.
Yeah, so it's a very well articulated guidelines, I will say. So first thing, the guidelines has categorized the atrial fibrillation. So the first the first stage, that is the pre-AF, in which the patient is having risk factors for developing AF, we should target the risk factors and we should treat as much as possible so that we can prevent the atrial fibrillation. In the patient who are having some structural remodeling of the heart, we should treat the structural remodeling also. Like the patient is hypertensive, LVH, or diastolic dysfunction, we should try to address the problem so that we can prevent the development of atrial fibrillation. And if the patient is having paroxysmal AF or persistent AF, we should treat them as early as possible by rhythm control strategy. We should not target the rate control in the patient who are, especially who are young, who are having a smaller size of left atrium, who are having LV dysfunction, because the more the time the patient is having in atrial fibrillation, the AF burden will increase, and there is more electrical remodeling, and it will become more difficult to maintain the rhythm in due course of time. So we should try the rhythm control strategy as early as possible in the patient who are deserve ablation procedure. In the patient who are having a very permanent AF, or who are elderly, who are having very dilated LV, and who are having a large scar on the ventricle, in which it is not very suitable, that rhythm control is not very helpful in them, then we can try for rate control by other means in those patients. So I will suggest that these guidelines focuses that we should try the rhythm control as early as possible, and we should try the by DC cardioversion also, because DC cardioversion, if we can maintain the rhythm, even then we can benefit the patient who are not affordable for the ablation.
So, thank you so much, Dr. List, for discussing these guidelines. And definitely, I think these guidelines, this discussion will add some uh, knowledge to the audience, and it was a meaningful discussion with you. And thank you all members who have patiently listened these talk. And we will come back again after 15 days with a new topic that will be published in JAT and discussed with the eminent speakers for that. Thank you so much.